pleasure to introduce our visiting professor today, Professor Srinivas Prasad, who came to us from Thomas Jefferson, went to undergrad and MD, Boston University, did the master at Hopkins, an internship at Hopkins, moved to WashU, where he did his residency, Cleveland for the Spine Complex Fellowship, has been at Thomas Jefferson for 15 years. I believe some of you may have met him a couple of years ago. I had not, but it's been a pleasure meeting him yesterday. I'm meeting him some more today. And you're going to talk to us about how to educate this next generation that desperately needs education. Let's do it.
Thank you. Thanks so much. Good to be here. Thanks, guys. Thanks for coming in on a Friday. I know it's not your typical day. I hope the Zoom people can hear me and see the screen. And thank you for that very nice introduction, Jacques. It's a pleasure to be here. I think it's exciting to see what's happening here. There's obviously a lot of change and a lot of potential, and that's really what we came to discuss. But in building a spine program, or really any neurosurgery program, we think of the three pillars of it as being research, education, and clinical volume and excellence. And something that kind of gets forgotten a lot is education, and that's something that's close to me, and something that I've been kind of enthusiastic about and trying to figure out how to change that. So I'm going to speak a little bit about my journey in this neurosurgical education process, and I honestly am going to ask you guys for feedback on where you think it should go, since you guys are really the target audience. By the way, how many of you guys are residents and fellows? And then faculty? Perfect. And then any nurse practitioners, APPs, anyone else? Okay. So we'll talk about educating the next generation. These are just my thoughts, but I'd welcome any comments as well. And I think the commitment to education is longstanding. This I found from a presidential address 70 years ago, where really the only way to kind of secure the future of neurosurgery is to train the next generation. And so, it is important to kind of imagine what we're doing. I'm from Jefferson. W.W. Keene is considered maybe the first or one of the first neurosurgeons, well ahead of his time. He was really he was a clinician, of course, a physician. He was at Thomas Jefferson. He was in the 1860s. He was a surgeon, anatomist, pathologist. He set up pathology labs. This was in an era where neurosurgery didn't really exist, but he really committed himself to neurosurgery, neuroanatomy, and was considered one of the early professors. He was a full generation ahead of Harvey Cushing, who we all think of as being the father of neurosurgery in the United States. But he was it's amazing. Harvey Cushing really was had set up the Cushing Society in 1919. That's only 100 plus or minus a couple years ago, which I think is staggering. And of course, we trained, Manish and I trained at WashU, where Ernest Sachs was, the grandson of Goldman Sachs, and he, was obviously independently wealthy. He came out to St. Louis and became the first true professor of neurosurgery in a dedicated way. And the legacy there, of course, is colored, but at the same time, he was known to just say, listen, whatever equipment we need, I'll just pay for. We need to get electrocautery and the hospitals want to do it, I'm just going to buy everything. So he really was able to set it up, since he had deep pockets that he could use to realize his vision. And then, of course, most of these people have a background at Hopkins, where I did, as Dr. Morkos had mentioned, I did my internship. And Hopkins, especially in general surgery, was really started by this gentleman, Halstead. And along with Osler, who was on the medicine side, they really developed surgical education in the United States. And the model for education at the time was really based in Europe, and it was apprenticeship model, right? It's and we kind of have that on some level even now. It's you go to a place and you learn from specific people who do it. And, this apprenticeship models can look like a lot of stuff, right? I described a couple cartoons, but it can be this, where somebody's very thoughtfully and mindfully kind of guiding somebody else and learning how to do something. It can be this kind of model where it's watch me do it, and he'll kind of pick it up on the go and kind of help me with what you can do. And over time, you'll get better and better at doing it. There's this model of and I have a couple colleagues who are call me when you're ready and just have at it. And whenever you get to a point where you're not comfortable, let me know, and I'm going to be doing my own thing. And then there's this model of cowering residents and an attending that's kind of showing them what to do, but kind of angrily and stuff. But apprenticeship comes in all flavors, right? I mean, the idea of what a good apprenticeship model is something that every program is kind of defining for themselves, and every surgeon defines for themselves. And that's something that I struggled with at the beginning. I mean, you start out in practice and you think you're still one of the residents, you're still one of their friends and one of the guys or one of the people. And that's not really the case. I realized early on that my responsibility is really to make our residents as good a surgeon as I can make them. And that made me think a lot about what's the best way to teach a new, upcoming residents. So now I'm 15 years in practice, and I'm like, I really think a full generation older than you guys. Like, I think the way that residents learn now is nothing like the way I learned before. Most of us use the internet for video, and from an educational standpoint, if you have something you're trying to learn, whether it's like fixing your car or like how to, even traveling in a place or something like that, you're going to watch video content. You can read a bit about it, but I think most of us know that like you're going online to consume content that's easy to consume, which often means video. Education is a big part of that. And, a lot of educators obviously believe that video is going to be an effective and an important replacement for some text-based content. Most people go to YouTube, just over half go to YouTube to learn new things, whatever that means. And it tends to prioritize short form videos. So you kind of have this sense that it's bimodal. You'll go there and maybe watch a 3 or 4 minute video. Maybe you'll watch a 15-minute video. You probably won't watch a 1-hour video. That's at least the general kind of feeling, is that, video consumption is bimodal. It's like short or long form, and it prioritizes short form videos. And that's where like Instagram and YouTube Shorts and all of these companies have really prioritized, like, hey, we want a 60-second snippet. Like, nobody has 4 minutes or 30 minutes. I think that speaks to the lack of attention that people really are capable of paying. So that's like in general, right? That's the, in the general world. But this is an interesting ENT article that talks about, this is for ENT residents, looking at what type of resources they use. And this is percentage of time that they would spend on these types of resources. So textbooks, and I don't know if you can really see for review books, textbooks, still kind of at the top, but web search, video, podcast, if you look at these as being, like non-traditional sources of information, non-traditional sources now kind of are eclipsing traditional sources for education. And I think we know that, right? Like, people are reading books, maybe. Like, you get books to kind of feel good about yourself and like, all right, I have this book, but who's reading a book cover to cover? Like, that doesn't happen anymore. Like, people use them as a reference or as a resource in as much as they would use other forms. And I think that's sufficient. So in terms of learning a skill, I think this is an interesting kind of step model that kind of talks about what would it take to learn how to do, a lumbar fusion or a cranial case. It starts with, if you think about along this continuum, conceptualizing it. Like, if you're a medical student coming in and, are about to do a cervical, like, let's say a PCDF, for example, you don't even know what you're trying to accomplish. So just conceptualizing what you're trying to do is the first step. And then seeing it. And so, like, this is great, right? I mean, you can see it. You're a medical student. You kind of go to the room, you see it. You're PGY 1 or 2 resident or something like that. You're watching it. I emphasize the importance of verbalization. I think this kind of back and forth between them, this iteration on visualizing it, verbalizing it, is important. And I encourage our residents to like rehearse cases. And when you start out doing a lumbar or posterior cervical, let's say, you just kind of say exposure, instrumentation, decompression, arthrodesis. I mean, like, you kind of think of it in these very big steps effectively, but it gets more and more granular. And the more sophisticated that you get, like, I could almost walk you through every instrument I'll take and in what sequence I'll take them. You get more and more granular. And I think that comes with iteration and experience. And that's the thing I encourage people to do, because that verbalization process it really precipitates out what you're seeing, so that you're kind of identifying it as a discrete step. You're saying, and why did that person do this? And why did she do that afterwards? And I think that's important. This is really the focus of video. Like, a lot of this stuff you can iterate and do asynchronously. Like, you can't really practice it, right? Reinforcing it and correcting it, developing the mastery, developing autonomy. Like, these steps, I think simulation will end up being important. And I was talking to Dr. Morkos earlier about the idea of developing a lab here and being able to work with simulators. There's some encouraging simulators around the market, but they're all like nowhere near where they need to be. But if you look at like other domains like flight simulators, they were pathetic 30 years ago, and now they're really pretty incredible. Formula One racers, like, it's incredible, like, what you can do with simulation now. And we don't have anywhere near that in surgery, but certainly not in spine surgery, but certainly there's a potential for that. So you can imagine a world where you learn a lot asynchronously, learn a lot at the simulator, and then practice, in a sense, on patients after you develop some basic level of mastery. So that's kind of like the vision. The question becomes, like, how do we develop? Because we have to take the leadership in developing this stuff. Nobody's going to develop a simulator just for you. But developing it and making sure that it is anatomically and surgically accurate, I think, is really important. So my motivation, I've always been interested in education. I thought Khan Academy was pretty incredible in terms of like his vision as well and where it came from. But it grew kind of, I actually knew him when he was maybe an undergrad, and then he went to, he was at MIT and then went to Harvard. He was dating a friend of mine, and so we would hang out, and he had this vision for, that would be in the mid 90s, really. He had this vision for doing it, and it's like definitely takes a long time to develop it. But my motivators were a few. One of them is that, you get sick. I draw a lot. Manish may even remember that from when I was a resident. When we were residents together, I draw a lot in the operating room, and I draw out anatomy, and I explain why we're doing it. And I think that it's very different, one, for a surgeon to describe what they're doing with drawings, because you kind of highlight the clinically and technically relevant stuff. It's not looking at a picture from even Roten, which is an incredible resource where it's overwhelming. There's so much stuff. You almost need to reduce it to kind of the core essence of what you're trying to teach. So I think drawing does a lot of that. But at some point, after you've done 1,000 of the same drawing, it gets old. You know what I mean? And I can feel myself developing, fatigue of like, Lord, I have to do another one of these drawings again to kind of explain it. So content scales and time does not. And that's a quote I came across from some delegation book. But the short of it is that, if we can encapsulate what we do once, but do it really well, that it's something that you watch again and again and again. It has a long shelf life, and I'll kind of show that a little bit later, but it's like how we put in a thoracic pedicle screw 10 years ago and, now are basically the same. Like things have changed a little bit, but the anatomy doesn't change. That shelf life is huge. The fact that, compared to like a 2021 Honda Accord review, and it's like, that's no longer that relevant for most people. It's relevant in 2020 and 2021, and then it's gone, So the shelf life is valuable as well. Like what we do hasn't changed much. Personalized education, I think, is important. Like the idea that you're going to sit in a classroom like this and somebody's going to walk you through chapter 1 to chapter 10, it just doesn't happen. It doesn't happen in neurosurgery as much as people try, but people need to personalize it. Everybody's in a different place. So meeting them where they are, meeting students in a sense where they are is another motivation. There's a bit of, like residents want to be perceived as being like, intelligent and talented and have a good fund of knowledge. And I think that is everything okay with Zoom? I guess. Let me know if there's a problem with Zoom and I can change it. Oh yeah, no, it's okay. I just wasn't sure if there's an issue or something. So, personalizing the education, I think, is important. It's not uncommon for residents to feel like they're supposed to know something that they don't know. You ask them something,
they just cancel clinic.
Like, I feel like I should know that. People are almost embarrassed. Oh, okay.
Sorry, those of you on Zoom, please, some of you are not muted. Mute yourself. Thank you.
Perfect. Thank you. So not only meeting them where they are so that they don't feel in an environment somewhat anonymous where you can kind of like not betray the fact that I should know that, but I don't know that, like that's important. Because I remember as a resident being like, I'm going to go home and read about that. But it like never happens, because at the end of the day, then you get home and something happens and you never read about it as much as you want to. And so bringing accessible resources to people, I think, is important. And then asynchronous learning is important. Like, again, the idea, asynchronous learning, as I'm sure everyone can infer, is the idea that you kind of learn on demand, right? Like nobody like sets their cable box to DVR anything anymore, right? Everything is on demand, but it's not really like the idea that you're going to watch a Seinfeld at 7 p.m. on Thursday. It just like never happens, right? So the idea of asynchronous learning is also something that's important. Global reach is something that's important. Like I have gotten many comments from people in the third world, Africa, Southeast Asia, on some of the technical videos that I've sent out saying it's changed the way I put in C2 screws or changed the way I've done lateral mass screws or my understanding of the anatomy is different. Like I would never reach that person. And I think that part is very gratifying as well. The challenge with online content is it's mostly unregulated. Like you got people just putting out whatever. And certainly in spine space, there's a bunch of content out there that may be industry sponsored or self-promotive or things that are like, hey, check out how awesome this technique I use is. And there's really a paucity of educational spine content. And the reason I put this dishwasher code here is because I got this dishwasher code. And like, you get an E15 code on your dishwasher. Nobody knows what that is. There's no manual that you're going to find. But like, there's a guy who made a video on that specific esoteric error. You know what I mean? But like, if you want to go do an ACDF and you're a PGY2 resident, you've never seen one, there's no video to show you like, how do you position it? What do you think about before? What are the risks afterwards? Which I think is striking. So in our space, it's like, there's a huge void. So this had always been kind of like looming in my mind. And then in 2015, 16, I came across a group at one of the national meetings that was, trying to employ a device called a light board. This gentleman is Professor Peshkin. He's at Northwestern. He's obviously a very big innovator. And he's a fellow of the National Academy of Inventors, the founder of Mako Robotics, which Stryker bought for like an astronomical number and stuff. And he had developed something called a light board, which was a mechanism for teaching that kind of changed it from like the blackboard or the whiteboard to being like something where you're facing them. And the notion around it is pretty straightforward. It's a 4x8 sheet of glass. And now they come in different sizes and stuff. But imagine 4x8. So it's like a sheet of drywall, sheet of plywood. It's pretty big. It's illuminated along the perimeter. So you can kind of see that here, like there's lights in the perimeter. And because it's low lead glass or low iron content glass, it has total internal reflection. So the idea is that it's invisible. You can like record right through. You don't see anything until you want to write, and you write on this piece of glass and it kind of iridesces. So, it allows you to maintain eye contact with the viewer, as opposed to like what we remember from like childhood, or like this whiteboard where you're facing someone's back as they're drawing, and like it's easy to fall asleep. And then, people tend to follow the hands. It maintains eye contact. And with a video, it allows to be a little dynamic, like in the operating room, where I can start from something very straightforward and kind of grow an image so people can kind of follow along as opposed to seeing an image. So in 2016, I went out to Northwestern to use this one lab because the light board had been developed in this place. And, the idea initially was that it would allow you to synthesize different content. You take a PowerPoint, you could inject images, animations, illustrations, keep your view in it, etc., and still draw. And like this drawing, like this, you're like, okay, everyone kind of recognizes it. But if you're speaking while you're drawing it and kind of saying, let's say we're looking at this, and here's the pars, and here's the TP, and here's the pedicle, it kind of comes to life a little bit. And you say, now imagine where the nerves are, now imagine where the other stuff is. The ability to draw, I think, is useful. They had originally promoted it to be real-time production. You come into the studio, you do a shoot, you've got a video that's ready to, to post if you wanted to post it. And everything is open source. Like it's very cool. You want instructions to put one of these up, you can put one of these up. So the early vision was a few things. I wanted to create a resource for neurosurgeons. Well, I didn't know who the audience was, to be honest, initially, but I'll get into that a bit. I wanted to be non-commercial, unbiased, not really promoting anything or about revenue generation. So the focus is really like, how do we take what we do as neurosurgical professors, say, or educators, and bottle it? I wanted to allow for asynchronous stuff. So it's ad hoc consumption, allows people to watch it again and again, because you're probably not going to retain everything you see, but you can go back and be like, I got to look at that video one more time, or just like you'd read a book one more time, or an article one more time, but kind of make it easy for people to do. I wanted to be curriculum based. So a bit like you'd go through like, okay, cervical, lumbar, thoracic, kind of cover the entire spectrum of spine pathology that we see. And then I wanted to have high production value. So the question that always came up was, who is the target audience? Like, who are you speaking to? And like, I didn't really know. I was like, I don't know. I feel like this content is useful for anyone. I mean, it could be an interested patient, maybe a patient's family. Like we all meet patients who are like, more sophisticated than others and really want to know or fancy that like with a few videos, they could be experts. So who are you really speaking to? And I didn't really answer that question at the beginning because I didn't feel like restricting myself. So on the one hand, you've got surgeons, right? These are like, and this could be surgeons in practice, this could be aspiring residents, medical students, fellows, early career neurosurgeons, orthopedic surgeons. Again, in our world, we have to think about the ortho side of it as well. You can think about patients and families, and this honestly was an interest to me at the beginning. It's like, I hate saying the same thing to patients again and again. Also, I'd like to be like, hey, I think an ACDF makes sense. Give them like a 4-minute version and say, like, you can watch a 30-minute version that goes through everything in case I missed anything. And like, I think most patients, they like getting it. Like, they like when you say, go watch this, they're like, that's great. I think a small subset of them will actually watch it, but none of them will have the grievance that it's like, he didn't take time to explain it. When you kind of go through stuff and you say, there's this resource and you can watch it now, you can watch it later, when their daughter calls from like Colorado and says, what's he doing? They can send it to them. It was like just the idea of bottling it. Again, content scales, but time does not, And I don't know if you guys have to do this periodically, but like, can you talk to my son who's a therapist in California? And you're like, Lord, and then you're going to find a time to do that. And, like one of those things. So it's a lot easier to do that. You could also really spend time on the consent, right? Because how well do you really go through every risk? Here you could spend time, take notes. I'm going to record an 8-minute video on all the risks of whatever procedure we do, so that you're really bottling it and people don't feel like you're individual. Like they have a complication that's in this video and it's like, it's a known complication, like a C5 palsy after a posterior cervical. I mean, it sucks, but it's almost reassuring to patients. And they're like, no, there's a 5 to 8% rate of it happening. And it's not just, you're not like some anomaly, And then there's a lot of people in between. There's like spine adjacent staff, I would call them. So this is like nurse practitioners and PAs. If you think about it, you hire a nurse practitioner, your expectation from them is quite high. If they've just come out of their training program and you suddenly expect them to be like a PGY4 resident, like it's not going to happen. It takes a long time. And the resources available to train APCs are quite limited. They have programs or some educational content out there. But my feeling was like, you make a curriculum and people will find their happy spot, And this could be like scrub tech, spine reps. Spine reps is a huge one. Like, if you're Globus Nuvasive or Stryker or Medtronic and you're trying to hire, they have a 15% turnover per year. You've got to train hundreds of people every year. and they have to be able to go to the OR and not look like idiots. Like they have to look like they know what the surgery is about and why they're doing it. It's a massive training burden. So I didn't really know who I was going to be speaking to. And then outside of this, there's all the outliers, right? The medical legal community, innovators, engineers that are developing a robot for something or developing some other technology that kind of would want to know it. So the idea is like you make a library and then let people find their happy spot. So that's where I started. I started with cervical spondylosis because it just made sense. Start at the top, work your way down. And I kind of came up with a library that's a bit like, or a table of contents that's a bit like what you would find in a textbook. And it was just like understanding anatomy, understanding imaging, features, structural features of spondylosis, clinical features of symptomatic features of cervical spondylosis, et cetera. And I just kind of went through the whole thing and then got to like operative management and the nuances for like revision surgery and stuff like that. And it allows people to, again, find where you are. You're like a lay person, you can kind of look at, anatomy of the cervical spine or like what is cervical radiculopathy and things like that. So that was the initial vision. And I thought, and of course, I'm, working at Jeff and pretty busy at the same time. And I've encountered some challenges. Like the first challenge I encountered is like animations and illustrations. You cannot, like when you do a PowerPoint, you just go to Google Images and you cut a bunch of stuff and you put it in your PowerPoint. You don't think about licensure. But if you're going to put content out and it's going to be public, you need to have the license to use it, especially at scale. And there's lots of people that don't think about this, but I was not comfortable with not thinking about it. For fear that like somebody would come out later and be like, that's actually my image. And, so here I put on like, you can't just go take atoms, like you can cut this and crop it and make it look very pretty and stuff, but you can't just take that without them worrying that these guys are going to come after you. Also, you get all these like anatomically inaccurate, like the proportions is totally messed up. Like there's no spinal cord in the lumbar spine. Like you get all these images that just don't make any sense. When you're working with the universe of images that are out there, you're quite limited. And so that's a real challenge. It's also hard to create a cohesive theme, like in other words, I want the same color palette. From a production value standpoint, it's nice to have your own stuff. So that was the first challenge that I encountered. Then the video production stuff is the other thing. Like I can't fly to Chicago to record it. And finding studio time is hard enough. Finding a videographer to do stuff is hard enough. The post-production, like I'm not a video, like that time. I mean, I can do some rudimentary stuff to take a video, but it's not like something we're trained in, I could certainly never be as good as a professional. And then getting surgical footage is a real drag. Like part of the reason we don't have these in spine, because Aaron Cohen-Goodall has done an incredible job with Neurosurgical Atlas on cranial stuff, but you have a bit of an advantage if like the exposure is not that interesting, but it's really like the surgery under the microscope, because you can just record it. I mean, it's in line, you've recorded it, it's great. But like we don't use a microscope that often in spine. And so we certainly don't have, and sometimes the exposure is relevant. Like being able to do an efficient ACDF exposure, like unless somebody walks you through it, there's no video that shows you how do you position it, how do you actually mark it, how do you actually make the incision and perform the exposure. All you ever see in a video is like a retractor down and some guy taking out a disc and like where the cord, you see what you can see with a microscope. So like, we don't have great camera or scope options, or at least historically didn't. And then there's some cadaver lab stuff. So I got started. So in June 2019, I finally like put all this stuff together, put together an outline and thought, so it's like a few years. I mean, I kind of planted the seed when I went to Chicago. And I thought, like, I'm going to build myself a light board. It's open source. Like, I'll tell you what to get. You just have to order sheets of glass. This is my basement. And I was like, there's no way I'm going to be able to do it like on Tuesday at 2 p.m. Like I have to be able to do it on the weekends on my own when I'm ready for it and stuff. So I put it together. I put together a light board. It takes a bunch of computers and different video appliances to kind of left, right, reverse stuff and things like that. And it was a bit of trial and error to kind of get it all working. Bought a bunch of cameras. I've just got like, it's like just this graveyard of cameras in my basement now. Getting all the software for it, repurposing a room, figuring out light management, sound management, all that stuff can be a little bit troublesome. And then COVID happened, which was kind of a blessing for me because it was like, it just gave me all this time. Like suddenly I was home for, 3 months and we had young kids and it was awesome, but I could really spend time building this because Home Depot was a store that was open during the pandemic. And so I was able to like go kind of build this myself. So I changed the design. I'd already done like 4 or 5 shoots, kind of experimented with different backdrops and thought I'm going to go all in and take advantage of the few months that I have to kind of do it. So I put in like, I got a professional videographer because everybody was out of work. So I was able to get a couple people, talk to them, and they were like eager to come do it, take some precautions, et cetera. I got like acoustic baffling. I kind of really made the studio, and you can see my kids drawing it and stuff now, but made the studio in my basement in like a fairly high quality production environment, which I think, with wireless mics and multiple cameras and so forth, and the lighting is all optimized for this shoot. And I can just leave it up. Like I don't have to take it down, So I set up the studio and that was great. And then, the question became like finding a name. And like this, I basically settled on Spine Academy because you know how you find a name, you go to like Network Solutions or GoDaddy and just play in a bunch of stuff and try and figure out what URLs are available and then Google search. And I landed on Spine and Academy, which I thought was kind of cool. And I got spineacademy.org. And spineacademy.com, of note, was available for $6,000, which means it's like a troll, like somebody bought it, but it was like one of those things that ends with you can buy this site if you want it. And then I had to make a logo and a logo animation. And of course, I kind of went, again, this is COVID, so I could try all these different things and kind of settled on this idea that it's going to be Spine Academy. Like, that's what I'm calling it. I'm going to start rolling out videos. So I did. I hired a professional videographer, and the guy is like incredible. He came in and played with all these different cameras. He's like a very high level kind of guy that would do all the post production. I hired an illustrator. I hired an animator. I found an illustrator through Ian Sook, who was at Hopkins. Zia actually took him. Bill Costin took him from here to Hopkins when he went, and then when he went to Brown, Sook stayed on. So I called him, and how much do you think Sook's What do you think one of Ian Sook's illustrations costs? What do you think, Manish? $10,000. That's exactly right. $10,000 for a single illustration. And I was like, so I vomited and I was like, oh, I can't afford that. So, but he did put me in touch with a couple of his students who were excellent. He was like, in the last 10 years, these are the best two people. So I reached out to them and they're quite reasonable. And so now I work with Alyssa Siegel, who did all these illustrations, you know what I mean? And they're like, you can make them anatomically accurate. You can manage the theme. You can kind of make sure that, if you want to identify pathology, I can show MRIs and be like, no, this is what I want it to look like. Here's an X-ray. Can we make this an illustration? And so it's a tremendous amount of back and forth, to kind of explain the concepts that you want, but allows you to control it, which I think is really huge. Like I've been working, just to give you a sense of time, the reason it takes so long to make these, like I wanted to go make a video on screw terminology, which is like something that we ought to teach, but like, do you guys know what's a quad lead screw? I'm sorry, I don't remember your name, but what's a quad lead screw? Do you know? What's a polyaxial screw? Do you know? Do you know what a polyaxial screw is? What would you say? Moves, right? Yeah, that the head moves. What's a uniaxial or a monoaxial screw? Perfect. Yeah, exactly. So like the leads, fenestrated, cannulated, like like all this stuff kind of matters. Like what's the minor diameter, the major diameter? It's basic, right? It's like a 10-minute video, but it's like, we should know what a variable versus a fixed, cervical screw is, and like, so just making that, the reason I bring this story up is just making that video, she's been working on illustrations for 4 months now because we've gone through and shown her all this stuff, but to really kind of teach it takes forever. So it's like a very time consuming thing, but I got an animator. The animator did this great animation. He does all my animations. He's like an industrial animator. So I was able to kind of repurpose him for medical illustration. So I broke it down to these content architectures, and I basically say like 7 types of videos, like core curriculum, like what is cervical spondylosis, what is lumbar spondylosis, et cetera. Surgical techniques, which are like, how do you put a C1 screw in, how do you put a C2 par screw in, how do you put a C2 laminar screw in, lateral mass screws, et cetera. Like very detailed, like what are the landmarks, what are the, the techniques, what are the principles around it. Surgical procedures, which is the buttoned up, the whole thing, like you're doing an ACDF or a PCDF. It's like, how do you position? What do you think about beforehand? What are the risks? What do you think about after? What are intraoperative things you can encounter? How do we how do I sequence it, et cetera? Like, really soup to nuts kind of showing a procedure. Then pearls and pitfalls, which is kind of like the screw terminology, navigation, how does navigation really work, et cetera, the math behind navigation kind of stuff. Surgical cases, like here's an interesting case, here's how I manage it, stuff like that. And then like, FAQs and an educational series. So I came out with my first group of these. I rolled out 4 videos. I just said I was going to start with the first 4, define the chapter theme, the structure, came up with the logo animations and stuff, did whatever, all this stuff. And I came up with these 4 chapters. And my goal was not to get too deep into it without starting to vet it and putting it out there and seeing how it was received and, what the audience really, in a sense, wants. So in the context of all of that, and I do this mostly to explain why it's called Prasad Spine Academy, it turns out Medtronic had a trademark on Spine Academy Learning Series from 2008 that I encountered after I'd already made a bunch of videos and kind of I'm like deep into this now, right? Like I'm 3 years into it. So I had a bunch of emails with them of back and forth about like, you have it, can I use it? They use it for something else, et cetera. And basically where it landed is that I can use Spine Academy, but I have to put Prasad in it. That's like number 2 or whatever. It has to be at the front or the back. Otherwise, I have to remake all my videos. If I call it like Spine Institute, then I have to go back and be like, welcome. I have to make all my videos again, which is a bit of a drag. So I ended up saying like, it's reasonable for Srinivas Prasad to call it Spine Academy. I wouldn't say Prasad Spine Academy. So I ended up making it Prasad Spine Academy. So that's where Prasad comes from. It's really Medtronic that kind of drove that. And of course, after this back and forth for 3 months saying like, we have no real interest in that space, we use it for billing. they bought spineacademy.com for $6,000, and they said, it's your online resource for education and training. So I was like, so now if you type in spineacademy.com, it's a vanity URL that takes you to Medtronic. So I rolled it out under Prasad Spine Academy. I opened a YouTube channel. I don't know how to do that, so I hired a guy. He went through this and helped me kind of roll it out in sequence. And we talked about SEO optimization and addition of YouTube Shorts. And what I've learned is a few things. Like the pros of YouTube are that it's easy to start, right? If you had a bunch of videos and you wanted to post them, like you just go to YouTube. Like that's the easiest way to get them out there. Everyone knows what it is. It's got international reach. It's easy on the performance analytics. You can figure out what videos perform, what videos aren't performing. It's, kind of like you can subscribe to something and not feel like you're going to get inundated with something, right? If you go to a channel and you're like, yeah, I'll subscribe to this, sure. And it gives you some impressions and click-through rates. The cons are that it skews towards heavily general population. You know what I mean? Like the people watching them are basically like anyone that goes to YouTube that types in spine. You can't really target a particular audience with it, which is to say, like if I'm targeting residents and fellows for content, it's like, you just kind of put it out there and hope they get to it. The ads are just incredibly annoying because they're all kind of like weird constipation ads and like whatever that you have no control over, You also can't manage the journey. And that's a problem because it's like you can watch a video that's chapter 1 and chapter 2 is not the next video that comes up. It may not even be one of mine. It might be anyone's video can come up next. And, managing that journey can be very hard. Very limited organization options for it. You can have a playlist. That's about it, and limited audience analytics. You can tell if they looked at it on an iPhone or a Samsung Galaxy, but you can't tell like who it was or what type of, how sophisticated is the viewer, what country. You can tell like very basic stuff. So if we get back to this target audience thing, it turns out like this is the scale. I mean, like patients and families far and away were the highest viewers on it, which is a bit of a drag, because and YouTube rewards views and click-through rates and subscribers and stuff like that. So like nothing in neurosurgery. I mean, how many spine surgeons do you think there are in the United States? What would you say? When you guys? Yeah, it's about 4,500. When you think about ortho and neuro combined, it's about 4,500 to 5,000. Round up and say it's less than 5,000, but let's say it's 5,000, right? I mean, that's a small number. Like if every viewer that was a spine surgeon and every trainee that was in spine or ortho or neuro, it would still be like order of like 6,000 or 7,000. It's not like that many people are going to be watching these videos. So it never quite kind of ticks anywhere on the radar for them. Then you get to like, what are the motivations? Somebody who's targeting patients is looking to increase the demand for their services, and like you get a bunch of these guys that are out there, you can pay for views that are out there just trying to get more people calling for an appointment with me and saying, look at the cool stuff I do. And this is the cool, I'll use an ultrasound or a laser or a robot or whatever, endoscopic. And you're just trying to drive up demand. That's not something that I need. That's not something you guys need. I mean, like you guys have tremendous volume here. You're not trying to get more people in the door necessarily. And the comments and questions are just staggeringly painful, because it's like, everybody's like, I've got this numbness. I've had 4 surgeries. Can you tell me and you're just like, even to respond to those and say like, I'm afraid I can't offer good guidance on that without seeing you. Even that is time consuming, you know what I mean? To just get to all these people. So the comments and questions are brutal. But what I've learned so far from a YouTube channel is this. Surgical technique videos far and away perform the best. So like, this is just, I took this, like I gave a talk variant on this talk at Jefferson in February, and I took this thing out that kind of talks, I mean, if you look at, I have like 100 and something videos. The surgical technique videos represent 4 of the top 5. But what's interesting about this is that if you look at this from February and this from last night, like they tend to grow. They have shelf life. And now I've gone from like 9,000 to 13,000 views. It's not a lot of views, but if you think about it, there's only 5,000 spine surgeons in the United States. And the patients are not the ones watching like how to put a thoracic pedicle screw in. But what I learned is like anatomy of the cervical spine gets like 500, like nobody's interested. You know what I mean? And I take a lot of time. I mean, it takes time for me to kind of roll out like anatomy of the lumbar spine. Like why make that video? The audience, in a sense, the opportunity for making a few and putting them out there and making all those different subtypes and seeing what sticks is that I can learn from that it's like surgical technique and surgical procedure videos are really what in a sense, my target audience wants, the scale will always be small by YouTube standards. Like it'll never blip the radar at all. Like it's going to be thousands, order of tens of thousands of viewers. It's not necessarily the right medium for me. Structure matters, like a rational educational journey matters. It's hard to just kind of like, I do get questions from surgeons and, surgeons and trainees and stuff on it, in the form of comments or emails, where people like clearly just didn't get to the next video. It's like something that's clearly in the next video, but it's like they just didn't get there. So like finding what you want and being able to navigate that journey, I think is important. Duration doesn't seem to matter, to be honest. I mean, I think people watch the bits they want, like even if it's an 11-minute video, people will watch it and watch 3 minutes of it, but it's just the 3 minutes they want. And so actually having this bar at the bottom that tells you what, the section is and stuff is kind of more valuable than anything else. Pearls and pitfalls, they're okay. I think that they kind of get this smattering of ongoing things. And then, the layperson's audience is a burden. So I've really narrowed my target audience to being surgeons, surgical trainees, still want international reach, still kind of appeals to some medical students, but the focus is really going to be on the sophisticated APP and surgeons and trainees, which was like a relief for me, to be honest, because that's what I do every day. Like to really make content on back pain is not that easy. So now I've partnered with CNS, but the goal now is that my mission, which is to teach people and to kind of create free, as I mentioned before, not commercially biased kind of content, aligns pretty well with the spine educational missions of most organizations. And CNS, Nader Paratian, he was the head of the CNS, and Elad was the president. So I was talking to Elad about this, and he's like, we got to do it with CNS. Like, we have a YouTube channel, like, let's get it on YouTube. And like that ended up happening. But the goal of it is to kind of, if my target audience is residents and fellows, is to reach out to residents and fellows and surgeons through the national organizations. And so, I partnered with CNS, and NAS and AAOS I'm working on right now, but everybody's quite enthusiastic about it. The question is really to expand the awareness. And what's neat about this is like, so this is like the CNS channel. They have a playlist for me. Like, these are all of the CNS videos. Like, in February, it was these two. And I actually didn't pull it out yesterday. I pulled it out like a few weeks ago. You pull it up, it's like they're growing. They're like, all of these are 11 years old. Like these ones are 6 months old or 7 months old or something. And it's like, it's gone from being like 9 and 10 to being like 6, 7. Now it's like 5, 6, 8. I mean, it's like, it's growing. Like there's interest, there's reach. It clearly shows CNS that it's like, of all the videos they spit out, and they spit out a bunch, that the ones that have staying power and have some utility are these educational ones, like truly educational ones, not like bottle a talk that was given at CNS and put it on there, or a talk that says like, come to CNS and wherever, those like get 100 views, but it helps to, when you put it in YouTube, it looks like, man, there's no interest. When you put it in CNS, it's like, there's a fair amount of interest relative to the content that's put out there. And certainly like the fastest growing videos they have. This was an interesting paper that came out in January that basically just shows like all the online resources in neurosurgery. And I was pumped to be here. We actually have one of our residents has, these are not ranked, it's just they're out there. And there's no way like I'm ahead of a Roten Seattle Science Foundation, but it was nice to be in the same category with them, as being online resources for medical students going into neurosurgery. And they're not, I don't know who these people are, like they weren't like, we wrote our own paper. So the question is really what's next? And the goal is to take it like independent. So to take it off of YouTube. I'd like to manage the educational journey. I'd like to know who it is. Like I'd want to be able to say like, oh, this guy's a resident at UT Houston, or this woman's a resident at UW Seattle or whatever. Not because I care about like who the person is, but because I want to understand like the reach and where there's opportunity. And I want to welcome some online engagement. So it's like people say like a video of this would be great, or how do you do that? Like that, in a sense, it's an opportunity to reach the broader community nationally, but internationally. I do, as I said, I get a fair number of comments. Actually, some of the most engaged surgeons are surgeons from abroad, and it's Europe as much as like UK, Germany, Netherlands, Southeast Asia, like certainly India, China, Bangladesh. We get a lot of comments in Africa, which is really gratifying, I would say. It gives me the ability to kind of have design flexibility too. Like I could make it more accessible. So you went to a website and kind of understood what you're looking at. It doesn't have to be super sophisticated. And then you can go from there. You can synchronize, you can create text stuff. We can have certifications, like you've completed level 1 of the educational series or whatever. And I think that's an opportunity. And then now this is the thing I'm kind of most excited. Like my next step right now is to start making surgical content. And it's, and I'm talking about like skin to skin content. So it's like the question, if you're a PGY3 resident going into a case, what do you think about before? How do you counsel a patient before? How do you position, mark the incision? Stuff that our residents sometimes just take for granted. That's very much like something your PGY5 teaches you and your PGY2, and like you just kind of, errors potentiate themselves. But like if you really want to be exact, here's the considerations for it. And I just don't have the patience to tell people every single time on an ACDF, here's how I like to position it. So here's how I plan my incision. Here's the landmarks for it and stuff. But the idea around it is to kind of really go into surgical setup, the positioning nuances, and then skin to skin stuff. This is not, this is me operating in real time. Yeah, this is like 5X. But the point of it is to really show like regular cases. Like people tend to put their best cases up. This is just like, I took an ACDF, I'm recording it with different headlights. The challenge with this is that, when I'm doing a video in my house, it's like, and the video is not that interesting, but it's basically like, how do you actually go? This is something I encountered when I was a resident, which is why I'm trying to satisfy all of those things, where it's like, how do you get down to the spine? Like, it's almost like, how do you do it in a very sequenced way? And I feel like this is where you learn the way to do it from like 4 people that you do it with in residency. But that seems like in 2024, we can do better than that. So it's like, and I'm not saying mine would be the only one, but creating a library where you really get into what are the landmarks, what do you look for, how do you preserve whatever, when do you take the omohyoid, how do you take the omohyoid, you know, like that's something that everyone has a different way to do it. But I feel like it would be worthwhile kind of saying like, how do you go from like the patient being in the room but not positioned to looking at the spine, which is where this like little clip ends. And then I want to make things like decision-making frameworks, like how do you decide what to do for it? I'd like to create kind of a library of other people's perspectives as well, but I've learned not to be hamstrung by creating like the committee on stuff and just saying like, I'm going to start putting out content and then we'll see who is interested in joining. Case discussions, like, you know, being able to put cases up there. And then really get into like implant guidance and stuff, because nobody really, at least we don't, nobody talks to you to say, what do you look for in a screw? Like, I'm not biased towards the screw, but like, why do I like this system or not like that system? And what do I like about this system and so forth? I feel like there's some value in that. And then technique guidance, like my real world experiences with endoscopic stuff and lateral and prone transpsoas. And some people love prone transpsoas, but like, here's what I ran into with prone transpsoas. But it's like, I think it's useful to kind of get the content out there. And then you can start getting really crazy. Like, you would have like a podcast like these guys do, you know, the Kelsey brothers. I don't know, in Philly, you know, Jason Kelsey is huge. And you know, the idea of new heights, like this thing exploded. It's just like listening to 2 guys talk about inside football, you know? And it's like, I feel like there might be a bit of an appetite for like, hey, these are cases, what do you think about this? Like, I feel like those are always the fun, even at national meetings when people are up there and just kind of talking about a particular procedure, and it can be kind of fun and light and stuff. I feel like people get a lot out of that. And then lastly, one of the things, this is one of our residents had this idea, which I think is awesome, is just the idea that nobody reads the literature on a monthly basis anymore. And it's like, or maybe you guys, but I don't know anyone that does, you know, reads it on a regular basis. It would be great to have a regular series that just says, hey, in May of 2024, here are the 6 papers that came out here that are, here's the 240 papers that came out. Here's the 2 that you should know about. Here's what they show. Here's why. Because there's not really that many more than that. There might be 1 a month or 2 a month that are really worth it in the spine literature to kind of show. Because then I feel like you'd watch it. If it's a 10-minute thing and you're like, let me catch up on it. I mean, who's going to go through every journal and log in and like see what papers are there? It's almost like curating that is something that has significant impact as well. So people can kind of stay up on the literature without really without the burden. And I don't know what the future is, to be honest. I think the big question I have for you guys is like, this is what I wanted to kind of walk you a little bit through the journey that I took with Spine Academy and kind of where it's going. It's in its infancy. It's certainly like I'm just starting to get it out there more. I'm super excited about the direction it goes, but I would really welcome any insight you guys have into like where you think it should go. Thank you.
This is great. Besides you, is there anybody helping you besides the technique? Just you from?
It's just me, and I have a videographer who's been great, and again, the illustrator and the animator. Yeah, but it's like stuff I do on nights and weekends pretty much, you know? And I'll put up a shoot, but I can't, the cadaver labs are another thing, like all of my surgical technique videos and stuff like on C1 and C2 and whatever are all done in a cadaver lab with a really crazy setup. I mean, we have like this thing that looks like a giant endoscope and multiple cameras and stuff, because then you don't worry about sterility. So you can really kind of get into the details of it. I mean, of course, it's a cadaver, but setting up a cadaver lab, I've worked with usually I'll piggyback onto an existing cadaver lab and just use the cadaver afterwards. And so like, I think those guys help a little bit as well. But for the most part, it's just me doing it. But I wouldn't say I'm territorial about it. I mean, I've had actually one of my friends from Wake Forest who asked if he could come up and use it to kind of record some content. Like, I would welcome, you guys want to come up and use the studio, use the studio. Like it's here. I've talked to my tumor guys about, you know, colleagues and stuff about like, come out, it's in my basement. Like you can use it whenever you want. So I would say I put it in my basement so that I could access it, but I would welcome anyone else to participate. I don't think you can achieve real scale on like as a single person though. My goal would be to then come up with a library and say like, how do we get more content out there? Like Ortho Bullets has done a great job. I mean, it started out with like I don't know if you guys use Ortho Bullets, but it's like, it's a compendium of resources from a lot of different contributors. You know what I mean? What you lose there is you lose the ability to kind of, for quality, like you can get some heterogeneity, but if you are able to kind of regulate that and select just really good people that really do good teaching and stuff, you can keep the quality very high. But definitely I would need to expand it to more than just me. This whole journey was to figure out like what types of content are of interest, what's the right medium for it to be on. And then my next step would be to come up with a full, you know, curriculum around that. Because at the end of the day, we only do like 15, maybe 20 different types of spine surgery. Like that's not that many. Like, I mean, I would take a day and I would set up like 2 surgeries and I would have the videographer and do the shoots. And once it's out there, it's out there. I mean, how many of those do you need to do? But my feeling is like, the reason it took me so long to get this, it's been more than a year now that I've been negotiating with Jefferson on ownership of it. Because if I record it, like all this is in my basement, and we already have established, like they don't own any of it. It's like mine, I kind of do it myself and whatever. But the surgical footage is done at Jefferson with Jefferson Resources. So who owns that footage? And we finally landed on very agreeable terms around like, how that's managed. And they were very open to it because the argument is like, this content is getting out there. And it's like better for us to proactively say like, what should an institution do to protect the patient's rights and the patient's privacy? What should an institution do in terms of like controlling it, but not limiting dissemination of it? And so it's been pretty, like there's so much work that happens after the fact that the end product will be mine, but the video is theirs, and there's some constraints around how we have to protect information as we record it. So that took a year plus to kind of hammer out. So now as of last week, that's established. So hopefully I'll start making content. No, I mean, I think there's monetary models around it, but it's like never been the motivation because then it distorts, I think, where it goes. You know what I mean? Then I start, because I explored it, right? I mean, I could sell this to spine companies and say, hey, I'll make a curriculum for your reps and now you can kind of bottle it. But like, it's not really what I want to do, to be honest. Like we could, and I'm sure we could get pieces of this and maybe that would be of some interest and stuff. There's models around monetizing it, but that's not the motivation. Joe, did you have a question? Yeah.
No, so is this self-funded?
Yeah. 300 grand so far. It's a lot. But I've been doing it's over years, and it's I don't care. I mean, honestly, I feel like it's a worthwhile investment, I would say, because it really does scale. I mean, I think, and it really is exciting. I mean, like the comments that I get, I know these sound really cheesy, but it's like to wake up to an email from some guy that says, I've always done C2 laminar screws because I never knew how to do a C2 par screw. And I used to do every type 2 odontoid fracture down to C3 or have some cockamamie. I mean, it's just, and now it's like, I did my first C1-2 like you taught, and it was amazing. Like, I think that's awesome. Like, I feel like it's money well spent.
I feel like the ultimate goal for this would be to solve the curriculum such that someone could theoretically learn what they actually on the office could learn basically.
Right.
This would be something overseas where the question that I would have is how can you actually gauge the impact that your patient survey has, whether that be we have views obviously, but I mean like how else can you gauge that ultimately will tell you like what your impact will be?
Yeah, I don't know. That's a great question. I mean, I think all you really have is views, right? I mean, it's like, and I was at what was the joint section, and like, I'm sure not many people know. I have done very little to promote this, but it's like, I still had like 5 or 6 people come up and say, hey, I've seen your videos. Those are awesome. Thanks for making those kind of things. So I feel like you get some sense that it's kind of getting out there slowly, but you're right. In terms of impact, I don't know how it will actually affect people's practices. But in a sense, you train people and then they go out and they practice. And you don't know if they're doing it the way that you taught them. You know what I mean? Like if people go out and they continue to evolve. I don't know. Do you have ideas on how you could do that? How you measure impact?
Well, so I mean, like that. I mean, the problem with us is that science word of mouth, right? Like me telling residents, me telling other faculty members, hey, look at this out.
Yeah.
Like,
oh, my goal. Yeah. Well, my goal would be to initially, if you want to know, like really get into the weeds on it, it's like I want to roll out a website that's well designed. That's like easy. The architecture around it is straightforward and easy to navigate. And then it will kind of be member-based. I mean, the membership will be free, but it's basically like residents, fellows, like you'd sign up for it in the sense you kind of know where people are and what they're doing. And then it would be, and the only reason for that is to be able to say like, what % of the people viewing it are residents? What year in residency are they? What do they find interesting? You know what I mean? Like a PGY3 uses these videos, because then it would almost help inform like a curriculum down the road, where you said to complete your PGY3 year, you have to have completed this curriculum. You know what I mean? Yeah.
Where you start, this is how you have to that be video thing. So that's what I was thinking.
Course. Yeah. I think you might have missed the beginning parts. Khan was like one of my motivators for this whole thing, and I think that Yeah, and the idea of also navigating the curriculum is an important thing, like having it be structured so that there's a journey that you can understand. And like, this is where you have to meet people where they are, though. So understanding the journey that people take will help inform kind of the design of the journeys going forward. Yeah, I mean, those are great comments and great thoughts on it. I would, I think the next step for me, though, is really going to be to roll out a website, have this content, and in parallel be recording surgical footage because it takes so long. And then to be assembling the library, and then it's actually kind of easy. I feel like I would just email all the program directors and program coordinators. One of Dave Limbrick is actually the head of as the Senior Society. He's doing the program at Senior Society in June or something like that. So talking to him about that's an easy way to reach chairs and program directors as well. So getting in front of all the residents in neurosurgery, I don't think is so hard, to be honest. You know, I think it takes a bit of promotion. I just don't want to drive people to a YouTube channel right now.
Maybe we should ask the residents.
Yeah.
What is the best way that they learn?
Yeah.
You're looking for feedback.
I am. Yeah.
I encourage you. What is the most teaching format for you?
So I mean, finishing med school, everything like this is incredibly important because undergrad and med school, everything that I learned was an online visual resource.
Yeah.
Right. Even like my teachers in undergrad that would lecture us would put their lectures online and we would not go to lecture.
Right.
Because you could pause and try to do things at your own pace. Because it's a much nicer way to learn. One of the things that was really nice in med school was the resources having like
Yeah.
or something that has illustrations on there that I can take notes on the side of it. And kind of pause and play back, and that could be like distributed.
Yeah, that's a cool idea.
Right.
Yeah.
A lot of things like Boards and Beyond or Pencil Mark at school. You just kind of like
Resource that you can take notes on. Yeah, supplemental thing.
Yeah, as part of
Yeah.
As part of it. But again, like this is how people are learning. Yeah.
Cool.
Like residents are using the foundation and tailor it to
They do it their own way. Yeah, yeah.
having
Yeah. This is just meant to kind of get you up the steeper part of the learning curve. You know what I mean? So you can appreciate the nuance. Like I learn watching surgeons now, and it's like, oh, why do they do it that way? Why do they do this? But it's like, but where I'm starting from is very different than where you're starting from as a PGY2. The idea here is just to get you to a point where you can appreciate the nuances and the differences. Otherwise, you just think this is the only way to do it. Like this is how we do it, which is a Jefferson thing to say. You know what I mean? But I feel like you should be able to understand where all of it comes from and evolve it and adapt it and kind of take different pieces. Because I'm now trained with 30, I always say I trained with 30 different people that did spine surgery. And it was like, between WashU and Cleveland Clinic and then at Jefferson, I operated with all of the spine surgeons there. So I feel like I've seen 30 ways of doing everything. I don't know who I learned it from anymore. You know what I mean? Like I got little bits from everybody. But like getting you to the point where you can take little bits from everyone is kind of the point, And I think it would be awesome to have resources in the ACDF thing that show 4 different people doing ACDFs. You know what I mean? But it's like, it's hard to ask someone for, I want this quality. I mean, it is a pain to kind of make these videos. You got to have like an exoscope up in space. You got to make sure your head doesn't block it. You have a videographer sitting there to make sure it's in focus, that you're adjusting it. I mean, it's a pain all to get like what will end up being like a short video at the end of it, So asking people to do that can be a little bit tricky, but I would love it. I think it would be a certainly richer resource for that. Yeah. I just did, but only with Globus. I have one on the 29th, whatever that is. I'm meeting with the Brain Lab people to kind of go over theirs. I should try those. I looked at Google Glass when I started this, but I haven't done the meta stuff. Yeah. Yeah, I'll try that. I mean, I think it would be great. I don't know how to get the loops light thing around that. That's like been a bit of a challenge for a lot of those things that are heads up. But I mean, there may be a way to do it. I mean, it really comes down to having a very small camera. And I have a bunch of them. I have like the Swiss one. I'm looking at the Synvivo one now. It's like, you just want a camera that's between your loops effectively, but then eliminate shake, because it tends to bounce and you're always like looking at the tray, like, you're looking at the table. The amazing thing about spine surgery, and probably one of the biggest frustrations of any surgery, is that you only have one scene in one take, which is like when you're making a video, you'll be like, all right, scene 3, take 2, take 3, take 4. You know what I mean? It's like, oh, I was sweating. Did I blur that? Every patient, like, as soon as something gets screwed up, you're like throwing out the whole thing. You know what I mean? You're like, let's start again next week. You know what I mean? It's like, it takes a long time to get one that's really assembled well, because you can only do one take on them. Cool.
Your video will be
That's awesome. Thank you.
Much like your rankings, like top overall sort of thing. The one that wasn't in the video.
Yeah, yeah. Yeah. Exactly. Yeah. And they're growing so fast, which is kind of awesome. If you think 4,000 views since February, it's like kind of, and I don't really scrutinize it, but it says that nobody, and people are coming back to it. I think that it has to, there's not 13,000 individuals that are interested in the world, really, you know? But there is a huge space here. I think it raises the question of what does influence mean? You think of influencers in fashion and cars and whatever. What does influence mean in spine surgery, you know? Because if you think about it, for cars, everybody that watches a video on like a Tesla or the new BMW or whatever, like, you know, like what percent of them are buying that, you know, like a tiny percentage. Yet the 5,000 spine surgeons in the United States spend $10 billion a year on implants. It's like pretty crazy if you think about each person spends $50,000 on average a week. I mean, it's a staggering number. And you're spending $50,000 of someone else's money, right? But I mean, if you really think about the revenue model around it, it's kind of like, is this an ad-based thing? Is this an influence thing? Or should we be having like sponsorships for the channel? I mean, there's ways to go about it that I think could, you know, pay for stuff like these resources you're talking about. But the goal has never really been to like make money on it. But it does raise the question of what does influence even mean? It's a very different space, you know?
Your relationship with CNS is ad hoc, or are you?
Ad hoc. I was on the education committee for many years, actually, but I'm not now. But that's where, so Nader, when he was, I think last year, the committee chair or something, and he is the person I worked with primarily to kind of get them out there. It's ad hoc, yeah.
Because I just finished populating as a AANS, but I finished populating my AANS committees. It would be great to add you to the education committee of the AANS.
Sure. Yeah, I'd be happy to. I've been on the, yeah, I would be happy to. I think that would be great. Elad was very particular, though, just so you know, and not to tell on him. He was very particular that I not work with AANS if I work with CNS, though, which I thought was peculiar. He was like, listen, it can only be, and I was like, well, what about AAOS? And what about NAS? And he was like, those are okay. But like AA, I mean, he was like so particular that I'm happy. But I mean, I don't get anything from them. They don't pay me for anything. I mean, I'd be happy to say like, take it down. It was really just an opportunity to show that there's an appetite for it, you know? Like CNS just put it on their video, like any other video. Like, no, they didn't promote it. They're not sending out videos on it and emails on it. But like people are seeing it and it's kind of growing there. It was more to make the point that it's like maybe we should, as a society, be reimagining the type of content that we're aggregating, you know?
Okay. Wonderful.
Thank you very much.